Laura Temin here, and today we're going to be interviewing Dr. James Connolly. We have Dr. James Connolly here with us today and really appreciate your time as an expert. And Dr. Connolly, you are a doctor of physical therapy with a specialty in orthopedics, is that right?
Yeah, that's correct.
Okay. And so what does that exactly mean for those of us who don't really know what that means? What exactly does that mean?
Well, so the doctor of physical therapy, that's a 3-year degree where you go to specialize in the human body, how the human body functions, and how to treat and diagnose conditions. And I specifically specialize in orthopedics, which is just different musculoskeletal disorders, because that's kind of my particular passion. And my background is actually having a stroke as a kid, and that affected me a lot orthopedically. So I have been affected by that, and that really hit me to where I wanted to specialize in orthopedics.
So that's a mouthful, and I have a million questions about that. So tell me, tell me, how did that, you said that having a stroke affected you, that you were a kid. Tell me your story about the stroke, and then tell me how it affected you in terms of this work that you're doing so that I can understand what that means. Because I think, oh, a stroke, um, we think, oh, there are lots of things that go with the stroke. So go ahead and share with us.
Right. So yeah, it happened when I was really young, when I was about 8 months old, and I've had a lot of surgeries and PT in result of that, which kind of got me into physical therapy and
PT,
stroke.
physical therapy.
Right, physical therapy, PT, yeah. So a stroke is, of course, a neurological damage, but with that comes a lot of orthopedic problems. It
Tell
caused
me
me,
about that.
so that caused me to actually have a little bit of a leg length discrepancy. So my left side's a little bit shorter than my right side. So I walk a little bit differently. So when you walk differently, you can have knee, hip, and back pain. Even though a stroke is a neurological condition, it results in these orthopedic problems, which I've dealt with all my life growing up. Hence what led me into physical therapy as a profession. And that's done a lot for me personally.
Wow. So you're saying that you have firsthand experience as a patient and you saw how much it could help. And so you decided to go into this as a career.
Right, exactly.
Help me understand how a stroke made one leg shorter than the other and the other things that you said. Help me understand that.
Right. So the interesting thing about this stroke when it happens is the muscles actually they become spastic is what it's called. So when a muscle is spastic, it becomes extra tight. So you think about muscle normally kind of in smooth, nice parallel fibers, or a spastic muscle literally kind of knots up. So it automatically shortens. And
So
when the
when we
muscle
have a muscle spasm in the middle of the night and our toes curl or something like that, that's what you're talking about.
right, think about that, but on a way bigger scale, times 100, and it's constantly like that.
And
Those
it's
ones at
like
night.
that for strokes for all people.
Right, exactly. And there's it's kind of like on a continuum. It varies from person to person, and there's different treatments you can do. So think about that annoying Charlie horse that just never goes away. Not pain
So,
wise, but as far as like how tight it is. So, and that causes the bones not to grow like they should. So not to get too deep in the weeds, but the muscles, of course, connect directly to bones. So if the muscle is super tight and connecting to that bone, it's not going to allow the bone to grow like it should. So the bone actually doesn't grow as long as, say, on the other leg. For me personally, on the other leg. So that's when I get that leg discrepancy from shorter bones.
all right, so I'm going to just keep clarifying.
Sure.
Um, so usually my understanding is that when a person has a stroke, it affects one side of the body. It's not
Mhm.
equal.
Exactly. Yes.
And so what you're saying is that affects the whole skeletal It affects everything. It affects all of the movement. What else does it affect?
So it can affect cognition. It didn't for me because I was so young when it happened. At 8 months old, the brain is very plastic. That's to say, it changes and it can adapt and overcome a lot easier. So it's actually kind of a blessing that I was so young because I was able to adapt and not have any cognitive dysfunction. So for me, it's just my left side, my arm and leg are a little bit weaker, and then I have the leg discrepancy on that left side.
So when when a person has a stroke, they will have lasting effects of that nature.
Yes, exactly.
All strokes?
Yep, and it depends on the type of stroke and where the stroke is located in the brain, uh, how long the bleed was for. It gets really complex, and if you catch it early enough. For me being young, and they caught it early because I was actually at the hospital when it happened, so they could treat it super quickly. So the older you are, the longer it lasts. I have seen a lot of patients that have more cognitive and physical deficits that are really permanent and that they can't overcome without medical intervention.
So you were very fortunate that you were in the hospital when it happened.
Yes.
And so, and you also said, so they were able to catch it right away
Mm,
and stop it from getting worse. And then you mentioned that you had more physical therapy yourself
mm.
as, and to tell us how physical therapy helps a person with a stroke. How does it help with the muscles and all of the things that are related that you do?
Right. So think about whenever you have, like I said, physical therapy is treating the body from injuries to help them recover more appropriately. So think about when you have a stroke as like a bad injury on the whole body. So for me personally, I had to learn how to re-walk. My fine motor function on my hands wasn't the same. So I actually had, occupational therapy as well. So I learn how to re-write, right? But basically, you go in to see a therapist, and they would work on the tightness of your muscles. So you've got range of motion that we look at, the range of motion in the joints. You've got strength, and then you've got coordination and balance. And that's a big part of it. Is the balance is always off in stroke.
Say that again because I want to write that down because those are really important things. So
Mhm.
you say, go ahead, say it.
So we work on mainly strength. We
Yeah.
look at strength deficits in the body, range of motion. So that's where, you're moving your arm through a whole range of motion in the body. You're looking at the joints, how they're moving, and then also balance and coordination.
Okay. And so so you how do you work on I can imagine only because my husband had something going on with his leg and so he had to go to physical therapy and they had him doing, some like something on your toes, like stretching
Okay.
because of the toe thing
Stretching out his calves, probably.
and but tell me about coordination and balance and actually so you're moving the body parts in a way that allows them um how is moving these body parts because if that's what you do, which I think that's what you do,
Exactly.
how does that get I could see how it would um make for flexibility because you're stretching them. But help me understand, and I could see the range of motion that um, you're stretching them. So you know the more you stretch that way, the more you'd have a range of motion.
It's gonna get, and that helps with spasticity. And I think I know what you're getting at.
Okay.
And the way it helps retrain the body is kind of like anything else, right? Whenever you want to do something, you have to make it a habit, and you have to do it over and over again. So we have to, and you can do it the wrong way and it'll be a bad habit, which of course we don't want. And then you can do it the right way and retrain you how to walk properly, for instance, which is what I had to do. And then you're walking normally, left foot in front of the other, right, left arm, right arm. Sometimes I still have trouble with it, but you learn to do it the right way, and then
What do you mean? What does that mean? Sometimes I still have trouble with it. Like, are you cognitively thinking it, like still learning it? Like, oh, I have to move left, I have to move right, or
so not cognitively, but it's still like my balance is still slightly off, just because I still have a leg length discrepancy, and my what's called proprioception. So that's the sense of where you are in space. Like, you imagine when you close your eyes, the only reason you don't fall is because your body has these little receptors in the body that tells you where you are in space. So mine is slightly off based on that,
as
and
a
that's just
result of the stroke, it made the spatial awareness.
awareness, yeah, slightly off. And that's just something that's I chronically have to adapt to and overcome. But that has gotten better over time because, like I was saying, with habits, and you can actually retrain the brain. And that's where, when I was, since I was younger, the brain adapts a lot easier. So the more you just do something, the more it adapts. So think about it this way: there's certain spots on the brain called the homunculus, is a scientific definition, that when you move a body part, say I move my arm, that part of your brain actually lights up. And when it's not working correctly, they've shown through MRIs and functional MRIs that spot doesn't light up, but different spots of your brain lights up. So it thinks it's kind of like a different part of your body. So we can use that to our advantage, though, because the more we retrain something, the more you get into that habit, like I was saying, and your brain kind of realizes, oh, that's actually the proper spot to be training. And it kind of, because like I said, it's really smart, really powerful, and it just kind of retrains. And over time, this habit, it rewires the brain more appropriately, if that
So
makes
really
sense.
what I'm hearing you say is that because you're moving the body, you're communicating with the brain, and you're making
Exactly.
it very familiar to the brain that it is this part. And so you're rebuilding the connections that may have been broken.
Exactly. There's plenty of millions and trillions actually of neurons in the brain. So we're rewiring the brain, those neuronal connections going from the brain all the way down to the body. Every time you move, it's sending signals up to the brain and vice versa, to telling you this is the body part you're moving. This is how we're going to do it. And the more
So
you do it,
how,
the better it
sorry.
gets. No, you're fine.
So, because you're saying so many things that are so fascinating, now I want to ask about this and I want to ask about that. But so now I'm caught in a place where I think you said the brain didn't register this part that moved, it didn't recognize it anymore. And you're
Right.
saying that by keeping on moving that part,
Hmm.
it builds a connection just by moving that part?
Yeah. So think about it kind of like when you have something like a stroke. Um, think about it like you've got like a roadblock between where that connection is running and where you want the body to go. Say, for instance, from the brain to the leg, but there's been a roadblock there because there's been that injury. So it's not fully connected. It's not fully disconnected, but like just like a roadblock, you have to slowly get the cars out of the way or whatever, what have you, in order to make that road go freely and make the cars go up and down again freely. And that's kind of what I use for PT. We clear it up, and over time, it can run more effectively how it's supposed to.
So there's this roadblock,
Hmm.
and by practicing a particular movement, it rebuilds the connection in the brain.
Right, exactly.
Okay. And okay, so if I recap what you're saying to me, is
Hmm.
that we have the mind working in conjunction with the body. And so even if there's a loss, because brain is so plastic because we're always regenerating neurons. Is that what you're saying? That
Right, exactly.
we're always regenerating. Our bodies are constantly regenerating, and that helps us to regain use of body parts,
Right.
muscles, um, that
Even
we.
that you didn't have before, exactly. And even without moving, now that we got on this topic, now there's a new field called motor imagery. And that's actually really interesting because I found that even without moving a body part, you can just think about moving a body part, and your brain actually grows these new connections, the same exact ones that it needs as if you were moving it. So say I couldn't move my right arm, or let's say left arm for me personally, because my left arm was affected and I just couldn't move it because the stroke had affected it. Now I have full function, but let's say I couldn't move it, it was paralyzed. If I just thought about it, like close my eyes, think, move my left arm, move my left arm, and I just think about it over and over again, they've shown through MRI studies and fMRI studies that the brain actually makes those same connections, and then slowly but surely they physically can start to move it
And
over
that
time.
is awesome. What was the name of that? You
It's called motor imagery.
motor imagery. Well, you know what? It's funny. I mean, it's awesome that they're connecting those dots. But
Right.
years ago, there was a study that talked about people practicing basketball. And they had three groups of people. And you maybe even know about this study. I can't remember who did it, where they had the group that actually practiced, and then the group that just imagined
Yep.
shooting those hoops.
Uh-huh.
And then the group that didn't do anything. And there was evidence that the
It
people,
improves.
yeah,
Yeah,
they,
same concept.
same
It's pretty
thing.
fascinating. It's pretty crazy, and that just goes to show how powerful the brain is, right? Like, and that just goes to show how our thoughts can make such a big difference, not only for thinking about movements, but just thinking about anything. Literally whatever you think. There's a quote, and I can never remember who it's by, but if he just says, "If you can or can't, if you think you can or can't, you're right." And
Right,
there's a
yes.
lot of power behind that, because the more you just think about something, and that goes into goals and what you want to do in your lifestyle and more long term. But there's a lot of truth to that, because there's those physical that they've shown through studies that neuronal connections that you're making, and just daily by thinking different things. It's pretty incredible.
Yeah. So, so what I'm learning from you really is very fascinating, because you're saying to me that there's evidence now that they've already shown in this motor imagery that they're using the mind and the imagination to help the body parts work. Now, I know there's a certain chiropractor or a whole group of chiropractors who do mirror imaging. So if one side of the body doesn't work,
Exactly. Yep,
they
that's
show them a
another
mirror.
of the
And
working side, and then it literally, yeah, I love that technique. They use that with amputees as well.
and so is this um, an offshoot of this motor imagery? Because it
Yeah.
sounds like, well, maybe it's more of a mirror imagery.
Right, and it's actually there's a graded technique that you go down. So the first one is motor imagery, and once they have that down, once they can start to move it, then you actually go into mirror imagery, where you'll and the way I've used it is put a mirror in between like someone's legs. Say their left leg is amputated, you put a mirror in between their leg, and they look at the mirror, they move their right leg, and then they see the right leg moving, and they think it's that left leg moving. And the way it actually can work usually is if people are having a lot of phantom limb pain, they treat it by doing that mirror imagery, and it actually takes some of that pain away on the left side.
How
Because
does that do that? How does seeing that, so they see the leg as if it really is still all there?
yeah, and as it not just as if it's all there, but as if it's that right leg. So, and this goes back to the perception of pain. So people always think of pain as this thing that's like let's say I prick my finger and, of course it hurts. It's right at the site that the pain is there. But actually, pain is a perception of the brain. So the signal gets sent up the body to the brain, synapses at the spinal cord, and then goes up. Now, let's say you were, just for sake of the illustration here, let's say you were in a war, and you were shooting to try to get away from the bad guy. Now, if I prick my finger and I'm trying to get away from somebody, I'm not going to be worried about my finger. I'm going to be worried about getting away so I don't die, right?
Right.
So your brain's going to ignore that spot and just try to get away. And that's where I mean pain is perception. So if your brain says there's a bigger threat, don't worry about that spot, then you'll be fine. You won't worry about it until all the adrenaline has gone away, all your endorphins have gone down. So where that plays into the amputees is where, if the perception of the brain, you look at the mirror and you see that leg moving, it kind of tricks your brain, so to speak. Your brain's going to say, hey, that's my left leg moving actually. Oh, so, and it doesn't hurt because, that's the other leg. So it's not hurting, it's moving normally. There's no reason to send those pain signals down to that leg. And lo and behold, the studies they've shown, after doing this for a few times a week for 6 weeks, people have reported a lot less pain and more function because they're in less pain.
Right. And more hopefulness.
Right. That changes their mood. And you think about being in pain, it's not fun. People don't like it. It changes their whole lifestyle. So then that, anxiety goes down, depression goes down, and all without medicines. Because if you're like me, and I think you are, you don't like to dope people up on medications that haven't even shown to work.
Right.
So just something like using a mirror is great.
Yeah, I think that's awesome. So tell me more about it. So we have the imagining, and then we have the mirroring. And what else? Because all of that stuff is brain body connection. What else do you do that's brain body connection? Because those are things that make a huge difference for people, because they know, first of all, there's the opiate epidemic. And I also know people personally who have had such severe pain that you know, they wound up on pain pills, not because anybody was trying to get addicted, but because the physicians were trying to ease their pain, and nobody really realized the degree of addiction that happens as quickly as it happens with that. And so people get hooked on something, and then what happens, you know, not only do they have addictions, but a lot of the pain medications cause constipation. And then constipation means you can't get rid of the toxins in your body. And, you know, you might wonder whether some of the hallucinations that people have with withdrawals, is it because is it really the medication, or is it toxicity that's going on in the body? I mean, who
That's a fair
knows?
point. Yeah, that's a fair point. And that's why, in the first stage, try to get off your opioids as much as quick as you can. And I think a big part of it is people relate pain to a bad thing. They all of a sudden feel pain and they're like, oh, I'm doing damage to the tissues. I need to stop what I'm doing. And that's not actually correct. Usually what I find is when people come to me with injury, they're, 10 weeks out with low back pain. Well, we know tissues only take about 8 weeks to heal. So physically, there's no damage to the tissues. And that's originally, of course, what pain is, to show damage, and so it's a good
Wait,
thing
wait, wait. Let
inherently.
me understand you. Are you saying that pain is tissue damage? That's what causes pain?
So it can, but it can in the first, like, so say you have you strain your shoulder at the gym, and that takes 8 weeks to heal. That's good in the beginning. You rest it, you ice it, hopefully get some therapy. It takes 8 weeks to heal, but the pain's still there. So at that point, we want to get it moving more, because the brain's still in that mindset of, I'm in pain. That means you need to rest it more. It's
And
kind of
then you stiffen your whole body and you tense
exactly.
everything up.
That's a
And
protective response. You're tensing it. So at that point, it's we have the saying, pain or hurt doesn't equal harm. So just because it hurts doesn't mean it's doing your body harm. So at that point, we say that the alarm system, the pain alarm system, is somewhat broken, and we have to kind of retrain it. And that's where the retraining the brain that I was talking about comes in handy.
So how do you retrain that if it hurts me and I'm very reluctant to move it because it hurts me, and then I'm tensing up because I know you're going to hurt me? How does that, how do you retrain the brain with that?
Well, so this is an interesting technique that's just come about recently, kind of along the lines of mirror imaging. It's called pain neuroscience education, and that's talking about specifically taking those thoughts that pain is bad and pain is hurt equals harm, and kind of retraining it. So we do that physically by just getting people to first. I'll kind of take you through something here where you're, for instance, we just get them laying on the table. Say we'll say a hurt back just for ease of example. They got a hurt low back, they're laying on the table. I'll tell them, okay, I know, like I said, the tissue's healed. We know the tissue's healed because of what I just talked about. We just have to kind of get you moving, to get you slowly realizing and retraining the brain to say, okay, I'm moving. This isn't going to hurt me. I'm okay doing this. And the brain slowly realizes those connections. So we just get them started with gentle movement, and then slowly through graded exposure, get them moving more and more and more to what they can tolerate. Get them walking a little bit, get them slightly jogging. And then again, the brain just gets into that habit where it says, okay, I'm doing this and I'm not in pain. This isn't a threat to me. And over time, just like any other habit, it starts to rewire, get those neurons connecting differently. And then before you know it, 8 weeks later, 10 weeks later, they're back playing basketball or picking up the kids, playing with the kids, doing what they love to do, and that's the basis behind that neuroscience education.
So, so you're really talking about a whole combination of things. You're giving the body a new experience.
Hmm.
You're giving, you know, with the gentle movement so that it's not really pain. And then you're doing the motor imagery, and then you're doing that mirror, what
Mirror
was it?
imagery. Yeah.
Mirror image. And
Yeah.
so that's, I mean, that should take care of a lot of things. So that would, that works with phantom pain, that works with growing neurons. And so what can we do with the mind and the body? I mean, can we grow bones? Can we grow, what are our limitations?
So the jury's definitely still out on the growing bones part. There's different research out there for that, but right now it's more specifically related to pain, and we've shown some progress in that. There is something, with exercises. Not only do we get the pain release, but we also get this endorphin release. You have those happy chemicals in the brain. So you've got the endorphins and enkephalins, serotonin, and dopamine. That when you
What's kephalin?
enkephalins,
Oh,
so
enkephalin. Okay.
enkephalins, yeah. Those are the happy chemicals in the brain that get released when you exercise. The typical runner's high.
And I thought that was just endorphins that did that. So I didn't realize that there were more, that there was enkephalins.
There's like a whole subset of these chemicals that are released in the brain when you're exercising, and they can actually inhibit pain. They're called your endogenous morphines, your endorphins or your endogenous morphines, and then the enkephalins do a similar thing to where, and we utilize that when we exercise. We don't really think about it, of course, but that's why when you may not want to do it in the morning, but when you get up and exercise, you always feel better afterwards. That's that brain response to naturally heal your body instead of throwing it up there with opioids and trying to make it feel better. Why
And
not
so
utilize what we have?
what about, I know there are a lot of people who say they feel awesome when they exercise, but I also know people who they don't get that feeling at all.
Mhm.
Could you explain a little bit about that?
Yeah, and that's always the struggle, right? With anything, we may not always enjoy just straight up running on the treadmill, like we're in a little hamster wheel, but that's where it's about trying to find those things that you do like, even if it's getting friends involved, or going to a group exercise class, or just going out in nature and, walking, because that's shown to have extra benefits, being out in nature. So, that's what I always work with my patients on, is trying to find something that they can do to keep them active, because, it's not only going to help their body, but it's going to help their mind. So we got
So
to kind of,
when you do your physical therapy and you do the physical part of it of stretching or whatever the movements are that you do, would that be releasing any of the endorphins? Is that considered exercise? Or like what Elliot and I spoke of, what Elliot spoke about with that particular machine that he uses that exercises the muscles when a person can't, those kinds of machines, does that release endorphins? Do you know?
um, it typically, so from to answer the first part, when if I'm stretching out a patient on the table, that's just strictly elongating those tissues, making them longer. So you're not getting any endorphin release from that. But from the machine that you're talking about, that's a kind of an electrical machine, and it can, once you get to a certain threshold, it can actually release those chemicals in the brain, to make you feel better. And that's where it comes back to pain, to kind of override that pain signal. It can actually release chemicals in the brain and override that pain signal.
So help me understand this, because I'm picturing somebody comes to you because they have an injury, right?
Hmm. Hmm.
And so they're uncomfortable. And we're saying do movement, but it hurts when they do the movement. So how do they get,
Right.
I'm trying to understand, like, how does it
The
link?
progression. Yeah.
Right.
So, and it depends on how severe the case is. Just to give you a very specific example, if somebody came to me with, let's say a low back pain, because that's so common, in PT, and they're coming to me all hunched over and they can barely move. I'm not going to get over there and say, hey, jump on that treadmill and go for a run. That's not going to do any good. That's just going to flare them up, and frankly, they're not going to come back and see me, as they shouldn't. But that's where I'll probably spend that session, probably the first full hour, just educating them on what we talked about pain neuroscience education, and the way they're thinking about pain. Because if they're just feel for the move and they say that pain means I'm harming my body, then they're never going to get better. There's no point to try to just push exercise on them if up here they have a bad mindset about it. So I'll just sit there with them and say, well, how do you feel about pain? Do you think it's something that's going to harm you and you're never going to get better, or do you feel like we just have to kind of work slowly at this and slowly kind of retrain it? So I'll look at their mindset first, and then if they have a good attitude about it, a good mindset, saying, yeah, it's going to get better, we just have to take time, then I'll say, okay, well, what do you feel comfortable doing with exercise wise? And that first day may just be something as easy as them laying on the table and bringing their knee up towards their chest, and that'll kind of gently, very gently stretch the back. And doing that sends those signals from the back to the brain and vice versa, saying, okay, this isn't painful, this isn't hurting, so there's no threat. I don't need to send any threatening signals to keep having that pain signal going. It's just kind of constantly working at it, slowly relaxing, retraining the brain, like I was talking about.
So there's comfort with that. You just said something that took me down a road. What about the people with chronic pain?
Mm.
Um, how does that work? How do you help them?
Yeah, so that's a whole different beast, and that takes a lot of time. They'll be in and out to see me. It could be up to 3 months or so before they get back to where they want to be, and it's
That's
definitely
all?
well, yeah, and that's the thing, is that these people can be in pain for years. And I've literally had patients come to see me after seeing numerous practitioners, numerous docs, and they've tried different PTs, but they haven't had the mental aspect of it taken care of, and they're so afraid to do anything. And finally, after talking with them, I finally get them, because all these people, they have goals, right? It's not like they're just coming because they just want to be able to get around the house. They want to be able to enjoy life. It's a quality of life issue at that point. So I make it my mission to figure out what's going on and figure out how to get them better. And that's where this is really interesting with the pain neuroscience education again, that it's a big mindset change for them, and it takes forever, but slowly but surely I start to get them moving again. And it's the same principles that we were talking about. It just takes a longer period for them, and that's a lot more check-in. That's a lot more them coming to see me, maybe 3 times a week, just constantly checking in with them and seeing how they're doing with it.
So really what you're saying, if I have this right, is that chronic pain, even chronic pain that hadn't been helped before,
Hmm.
if you can engage their mindset and you can adjust how they're looking at it, and really you're talking about the fear aspect. I'm afraid to move because it's going to be worse. Is that what you're saying? That if you could adjust the fear of movement
Hmm.
and normalize it, and then show them the right way to move, and
Exactly.
show them and help their body stretch and be more relaxed, then you can take someone who has a chronic problem and dissolve it.
Exactly. And you hit on something that's a key part of it, is the right way to move. And there's not exactly this, because some people think, you always have to sit up straight or you always have to squat perfectly. And that's not exactly correct. Anytime you move in one certain way, it can irritate it if you do it over and over again. So I look at each individual person and I say, how is your body functioning now? And are you doing things throughout the day that bothers it worse? So we start there and then we kind of work backwards and say, okay, well, let's just try modifying it. Let's doing it this different way. The problem becomes when they just get in their minds, oh, I have to do it this way, but that hurts, so I guess I'm just SOL. You
Well,
kind of.
but you're saying that everything can be, pain can be removed from everything?
To an extent, it depends on the patient. It can definitely be made better and be made to manage it while having an increased quality of life. But a lot of the problem is the type of messaging that's out there, and it's not a blame game, but unfortunately, some healthcare practitioners just say, "Oh, well, you had back surgery, so you're never allowed to bend over ever again, or never allowed to lift things." And I'm like, "What are you telling them this for?" Like, then they're afraid just to move because you act like their back is made of glass and it's going to shatter at any moment. The back is a very the back is a very like stable, strong structure. We just have to. It's not when like I said, hurt doesn't equal harm. So at that point, they've just been fed these messages over and over again. They're starting to believe it, and then their mind is trained that way. So every time they move, they're, oh no, it's gonna break my back. I can't do that. So of course you're gonna think that. But
Well, that's an important point too. So I know a few people who have had I forgot what the right word is, but where they um
is it a fusion?
yes,
Yeah,
right,
the
fusion.
terrible
And
fusion. Okay, yeah.
so because they didn't have cartilage or whatever it was that they said they didn't have and that they needed,
Probably degenerative disc disease, and
or
they fused it back.
degenerative disc disease. And so, once it's fused, can it, if we're using the mirroring or using the mind motor imagery,
Mhm.
is there anything that we could do with that, or is that a, a lost cause?
I wouldn't say it's a lost cause. There's a lot of factors that go into that. So, unfortunately, back in the 90s when they first started doing fusions willy-nilly, they would fuse multiple levels. So, levels meaning levels of vertebrae, so you're only supposed to fuse one vertebrae, so like L4, L5, that's one level. But docs were fusing 2, 3 levels. So people's pretty much whole low back of their spine was fused. And after that, yeah, you're going to have pain no matter what. That's just unfortunately because you got to have to have movement. But
Why does that cause pain?
so if your back isn't able to move, whenever we're walking, our back inherently, especially the low back, has to flex and extend, move forward and backward. And if it doesn't do that, then it's going to put stress on other structures. Their other structures are going to compensate, and you're going to naturally get movement and not get pain because they're overworking. And imagine doing that your whole life. Say you had a fusion in your 50s and you're now 80, 30 years of compensating. And unfortunately, in those cases, it is very, very hard to treat. And at that point, it's a management issue. But if you say you just had a surgery a year ago and it was just one level, just one little vertebrae, and you have some pain, then there's I'd say 80-90% chance that you're going to be able to do what you need to do without any issues going forwards.
So if a person has a fusion, then it's less likely that they could, that kind of chronic pain, that's a problem. They can't really exercise, or the endorphins wouldn't work for them, or
No, they definitely would, because you still
mm,
got that good brain body connection. It's just about finding what would work for them and what they can tolerate. So, and that's what's cool about my job is that everybody's a little different, so I constantly get to see, hey, well, what do you want to do? What are your personal goals? And I get to kind of take them through that journey of 8-10 weeks and get them back, and they'll be like, hey, James, I came back in and I can do what I need to do now. And 10 weeks ago, they came to me and they were like, I can't bend over, I can't extend because my back's gonna bust into a million pieces. And so it's that mindset change is getting to their goals, what they want to do, starting with them where they're at, and not pushing them too quick, too far, because that can make the pain get worse and make the body spasm up more, and your brain freaks out and says, no, I don't want to do that. So it's a very gentle approach, and then kind of slowly progressing them as they can tolerate it.
so as a person who had a stroke and had the body problems of growth that you talked about, which I'm not really remembering the exact term, so forgive me.
That's okay.
But so, because as I'm understanding it, certain muscles are shorter, which causes, as you said, for you to walk differently. And then that's putting pressure on the body. And so would you say that you have chronic pain? Or would you say that a person in your position would have chronic pain, but because you understand how it all works, you work with yourself with it?
Yeah, that's a good question. And for me, and this is also with a stroke in particular. People who've had a stroke typically don't have a lot of pain. Um, yeah, so that's the good part. And we relate chronic pain in general in terms of the definition as any continual pain for more than 3 months in one area of the body. And mine in particular is if I walk too far, if I run too far, I'll get some low back and some hip pain. But I know what to do physical therapy wise, and I'm not fixating on the pain, so it doesn't last that long. But mine only lasts a couple days, so it's really a question of duration for chronic pain symptoms.
So, because I thought that because this muscle is shorter, and then you talked about the back being, if it was fused, that would cause, imbalances, and those imbalances would cause a person to maybe lean more heavily this way, or um, so wouldn't that apply also to whether you had a fusion or whether you had a stroke?
It could, yeah. So for me personally, why I have that back pain occasionally is because of that leg length difference. So the purely because of the mechanics of the way I walk, whenever I walk, I kind of hit harder on my left side. So I'm kind of constantly bending to that left side. So if I walk too far or I run too much, and that constant bending puts a lot of pressure on the left side of my low back, and that's when I get that pain. A fusion is when if since their low back can't move like it should, if they go to bend forward, they're probably not going to round their back a little bit, and therefore it puts more pain on their upper spine or on their hip muscles, and that's where they can get pain. So it's different causes, I guess, but the same outcome of that musculoskeletal pain. Yeah.
So, okay, this was this really helped a lot because in in hypnosis we work with people with pain, and we work with people with mindset, and so understanding how the brain works in relation to the body is
Right.
very helpful for us to be able to know even some of those techniques that you spoke about are things that we're already doing in hypnosis, is reminding the body how it moves. You can remember a time that you were running and it felt so good. And as you say, the studies of using the imagination create the same kind of effect. And that's what we're doing in hypnosis. We're taking an taking a picture in the mind and rehearsing the behavior over and over again.
Yeah.
And often, a person, they can't imagine, like, if they're in pain, they can't imagine themselves running and feeling good.
Yeah.
But if we talk to them and we have certain techniques that we use, like one of them is called switching, where you're watching a little kid run, and that little kid is having so
Uh,
much fun, and they're running and they're playing, and you realize that you were playing with that kid. Well, now the brain has been, as you say, tricked with the mirror. It's tricked in a way that, so it's already dropped in. And when you're in a relaxed state, as you are in hypnosis, and we're feeding you these images that you can't picture in your own mind because you have resistance to it, because, like you say, it's protection. I can't move, it's going to cause this problem or that problem. And so
right.
we're stepping in and being creative with that, and so to be able to understand how the brain works, and then to be able to talk to you and see
Yeah.
that that's really what you're doing. But for those people that can't do it because they have all those, belief systems that get in the way, oh, it's been too many years, or I know someone and they couldn't, and the last time I did this, this happened. And so we're working with a mindset to make it easier for the person to reach their goal. So, I think this is a perfect connection for us, because we could, um, if you'd be open to more patients, and it might be a good way for us to work together, send people to you to learn the proper way of moving. And for those people who maybe can't imagine in their minds, or they have too much, negative interference,
Mhm.
we could help them. And maybe
Exactly.
even it would be interesting, maybe you could show us what are proper movements, what are improper movements, so that we have some kind of idea of what that really means. And because, as you say, that the rules are, you stand up straight, when you bend this way, and
Right.
those are just things handed down that I get the impression from you may or may not be true. Is that
Right.
right?
Yeah, exactly. And you hit on a couple good points. And on that last one, for me, I move differently already. So I'm not going to be sitting up straight, or I'm not going to be able to squat a certain way or move a certain way. So it's all about modifying where that patient's at. And this is where I can relate to my patients, because I can just say, in fact, I just did a video on this like a couple days ago. I was like, look, everyone has different stuff that they come to the table with, right? We all just have to learn how to use those and modify them as I need to. So I'll show them, this is the way I move. This is what I have to do. And I've had to learn up in here, I'm not going to move, quote unquote, perfectly. But for my body, I don't have any pain when I move because I've adapted to it, and I've trained that mind body connection to say, this is how you move, and you're not in pain, you just adapt to it. So I think that's a big thing is relating to the patients and being able to say, this is where I've been, or I have this patient or this other client that has been where you are, and getting them to see it is possible. I know, and this is the mind's really good at this. The mind is really good at saying, staying in the here and now and saying, well, this is all I know, so I can't really relate to that. And that's where, we come in, I think, as practitioners to say, hey, but I know this is hard for you to see, of course, right now, but it is possible. You just have to set those mini goals. And I think this is where setting small goals for people helps them to see, hey, I am making progress. I couldn't do this last week. I can do this now, kind of slowly relating that to them. And then they can look back and say, hey, I wasn't able to do that then, but I'm able to do it now. So it's those little things, and I think that's a key aspect of it.
Well, you know what? I'm so grateful that you took the time to speak with me and with us today so that we have an idea, an even better idea of how everything works together. And I'm going to invite you to meet with us again and maybe
Yeah,
talk a little bit more about these things, and maybe build some connections so that we could reach out to you and we could refer to you, and have a that kind of relationship where maybe we could help your people, but you could certainly help ours.
yeah,
So,
absolutely. I love that. And there's one thing that you said that this goes back to a previous conversation that we had, that hypnosis is really about tapping into the subconscious and using that self-talk, because that's really kind of, we don't realize it, but that really is kind of hypnotizing. We don't realize we're doing it, but the more you just tell yourself something, you're going to start to believe it. And we use that in PT. They use it in other healthcare professionals, and there's science to back that. So I think that's a really interesting point. There's a lot of validity to that. But yeah, I
well,
really appreciate you having me on to discuss this, because I think it's an important topic.
it's my pleasure. And if a person wants to reach you and refer to you, do you want to give us your website and contact information?
Yeah, of course, I'd be happy to. So you can actually reach me at my email, resultsrehab1@gmail.com, or my business phone, 678-577-8828. And check me out on Facebook at Results Rehab, and I'd be happy to answer any questions or anything else y'all might have.